After this urinary elimination lecture, there's going to be a little bit of little HESI case study that you guys will have to do, and it's pretty, it kind of combines everything in and gives you a picture where you have to kind of make choices there. So that's on your canvas.
Due Monday morning.
Due Monday morning, yes. So this is my first opportunity to stand up in front of you and lecture. I'm not going to be the master that Kathy is, but thank you for giving me the opportunity to take part. We're going to talk about urinary elimination, and I made a PowerPoint that's pretty much exactly from your book because when we're learning to be instructors, they teach us that everybody has a different learning style. It's the instructor's responsibility to kind of get through to everybody. So I myself am so ADHD that I cannot sit down and read a textbook and get anything from it. So I figured that a PowerPoint just hitting pretty much everything in shorter terms might help you guys absorb it a little bit better when you're overstimulated. So our learning objectives for today are also from your learning objectives for this portion of your class. We're going to describe the structure and function of the urinary system, describe the processes involved in urinary elimination, describe the components and functions of electrolytes in the body, identify common alterations in urinary elimination, discuss altered urinary function, describe key assessments related to urinary function, discuss measurable patient-centered goals related to urinary elimination, identify nursing diagnoses related to urinary elimination, and describe interventions to facilitate normal urinary elimination. What is urinary elimination? It is the last step in the removal and elimination of excess water and byproducts of body metabolism. So it's your body's way of getting rid of the stuff it no longer needs. It's a basic human function with a high risk of being compromised by a number of conditions. This process starts in the kidneys, moving through the ureters, bladder, urethra, and finally outside of the body. The kidneys are basically the beginning of that process. They filter waste products from your blood as well as regulate fluid and electrolyte balance using nephrons, which are the functional part of the kidneys. And then in smaller detail, the glomerulus. They play a major role in the regulation of fluid and electrolytes. Approximately 99% of the glomerular filtration is reabsorbed into the plasma, leaving only 1% to be excreted as urine. So your body takes everything it possibly can to help your body and keeps it, and then only a small portion of what we take in is actually put out as waste. Proteins or proteinuria or blood hematuria in the urine point to possible injury due to the fact that large proteins and blood cells do not normally filter through the glomerulus. So if you're noting that on a urinalysis, there's a problem. Sometimes proteinuria can tell you somebody who's had hypertension for a really long time and not taking care of themselves, and it's an indicator of kidney injury. I had kidney injury with my last child, and there was protein in my urine after that for 5 years. So it takes a long time for your kidneys to come back sometimes. They are also essential in performing functions such as stimulating red blood cell production and growth in bone marrow using erythropoietin. So you're going to notice that your patients with chronic kidney conditions and those on hemodialysis, they lack this hormone and they're usually anemic. Sometimes they can give them erythropoietin, but there's also some other risks with that. So they're usually getting blood transfusions occasionally and not building all those red blood cells like they need to. Helping to maintain blood pressure and blood flow via the renin-angiotensin system. Did you guys go over this in anatomy and physiology? Good. It is kind of an intense system that you need to eventually know just in general terms, when you're starting out as a nurse. But It's the production of prostaglandin E2 and prostacyclin, which help renal blood flow through vasodilation. So again, with the blood pressure regulation, your chronic kidney patients are probably going to be on a lot of different blood pressure medications. They'll be on a lisinopril, they'll be on a calcium channel blocker, sometimes small doses to combine to try to get their blood pressure in check. And it's, changes a lot with their doctor's appointments and things like that. They'll convert things to other things to try to control it. And the kidneys also help to regulate calcium and phosphate by converting vitamin D into its active form. Patients with kidney impairment may experience problems like anemia, hypertension, and electrolyte imbalance. The renin-angiotensin system. This hormone system regulates blood pressure and fluid balance. When renal ischemia occurs, decreased blood supply, renin is released from the juxtaglomerular cells. Renin acts as an enzyme to convert angiotensin into angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 in the lungs. Angiotensin 2 causes vasoconstriction and stimulates aldosterone release from the adrenal cortex. Aldosterone causes retention of water, increasing blood volume. Everybody understands that perfectly, right? Good. You can tell me later. The ureters. A ureter is attached to each kidney pelvis and transports urinary waste to the bladder. Urine draining from the ureters to the bladder is sterile, and peristaltic waves cause urine to enter in spurts instead of the usual steady stream, just kind of like bowel function. Everything in the body has its little wave, like the ocean. Contractions during micturition, which is urination, compress the lower part of ureters to prevent urine from backflowing into the ureters. Micturition is when the brain sends signals to allow the release of urine from the body. This backflow, or urinary reflux, occurs from the obstruction of urine flow, such as by a kidney stone, and can cause infection, distension, or even permanent damage. And your body's way of letting you know that something like that is happening is pain. So a lot of times kidney stone patients will come in almost like they're in labor. It's happening in waves where the body's trying to rid themselves of the kidney stone and it's too large to pass through the system. That's how they know to come in and get treatment. The bladder is a hollow muscular organ that holds urine. When empty, the bladder lies in the pelvic cavity behind the symphysis pubis and expands when filled. In males, it rests against the rectum. In females, it rests against the anterior wall of the uterus and vagina. It consists of two parts, which is a fixed base, a trigony, is that how you say it? Trigony? And a distensible body, the detrusor. Normal pressure in the bladder during filling is low, preventing dangerous urinary reflux. Urine passes through urethral meatus to the outside of the body after traveling through the urethra from the bladder. There is such a thing as urethritis. A lot of times women have extreme pain in that, actual exit spot. And they'll be treated a little bit differently than a bladder infection. I guess bacteria that cause urethritis are not always the same that cause the higher urinary tract infection. And this is when you'll see them give the dark pill that makes your urine really orange. Yeah, Pyridium, because it helps with those spasms. The urethra passes through a thick layer of skeletal muscles called pelvic floor muscles, which stabilize the urethra and contribute to urinary continence. The external urethral sphincter, made of striated muscles, contributes to voluntary control over the flow of your urine. The female urethra is approximately 1 to 1.5 inches long, while males typically range between 7 and 8 inches. So the shorter length in females is the higher risk for UTI. That's why you'll see UTI a lot more in females. Males have a longer way for that bacteria to travel. The act of urination. Urination, micturition, and voiding are all a part of the bladder emptying process. Your bladder control involves areas of the brain such as your cerebral cortex, thalamus, hypothalamus, and brainstem. 2 micturition centers are located in the spinal cord, one for inhibition of bladder contraction and one for your bladder contractility. Bladder contractions are inhibited by sympathetic stimulation from the thoracic micturition center as the bladder fills and stretches. So because it's controlled, everything's controlled in your central nervous system. This is what they mean by a neurogenic bladder. People have had some kind of damage to their spinal cord or, brain, and they will no longer have that inhibition of bladder contraction or bladder contractility. A lot of times they'll have like a suprapubic catheter or something. The amount to fill your bladder to the point of urgency is around 400 to 600 milliliters. And you guys have probably already learned that, but it's about 240 milliliters when you feel the urge to go. Full point of urgency is almost double that. When appropriate, the central nervous system sends messages to the micturition centers, stopping sympathetic stimulation and initiating parasympathetic stimulation from the sacral micturition center. So you've got thoracic control, you've got sacral control, you've got a lot of spots that could be injured that could lead to problems with urination. When deemed inappropriate, the brain sends messages to contract the urinary sphincter and relax the bladder muscle. Factors influencing urinary elimination. Growth and development, more complications in children and older adults. You'll see a lot of babies have a kidney reflux where they'll experience multiple urinary tract infections, and typically it goes away. But there are times when they have to go in and do stents or do surgery, more in females than males, where they get these infections all the time and they can't cope with them. Sociocultural factors, if people do not have the ability to be hygienic, then they're going to experience more bacteria growth. Psychological factors, teenage kids that don't want to take baths, personal habits. I always tell my patients that are female that come into the ER with urinary tract infections, I ask them several questions, and one of them is, do you take baths or showers? Because if you take baths, you are typically swimming in your own dirt. And if you're going to contract urinary tract infections, that's going to keep happening if you keep bathing. Some people are prone to them and some are not, but that's one of the things I can tell them to do to not experience a UTI. And also, wiping from front to back. A lot of women don't know that. They don't have mothers that teach them how to stay clean in the right way. Fluid intake, you have to get enough fluid to filter through your kidneys to get rid of your waste. If you don't, your body's going to hold on to everything, that you don't want to. Pathological conditions, some people just have weakened immune systems. Surgical procedures, especially those requiring catheterization during procedures, and a lot of times we as nurses don't even know if they've had a catheter unless we read the operative report, which if you've ever read one, it's absolutely fascinating. You cannot get through it. So if they've had a catheter, they can be introduced with anything when they break that sterile bladder. Then medications. Medications that would maybe rob you of your fluids, like Lasix, and then you're not getting enough fluid to flow through your kidneys, might increase the risk for problems with elimination. Yeah, narcotics, yep. Yeah, and if a patient's coming out of surgery and they're on like a morphine or Dilaudid drip, that a lot of times that discourages them from urinating after surgery. And then diagnostic examinations. Knowing such factors are key to identifying and anticipating elimination problems. A lot of times if a patient has gotten contrast, they'll automatically want to urinate immediately. So different things to think about with your patients. Growth and development. One's ability to control micturition changes during the lifespan. Continence begins during daytime hours for developing children, so it's harder to get them to be continent at night. It takes a little bit longer. Older women have a decrease in estrogenization of perineal tissue that increases risk for UTI. Just like any kind of aging situation that you're going to come across with your patients, elderly people have so much risk for something like this. And you'll see it in males too, just because everything is not functioning like it did when they were your age. Consider all possible causes of new onset of incontinence, which includes noting any new medications that might impact cognition, alertness, mobility, or voiding. It's not always related to just aging. I had a 94-year-old woman the other day who was fully continent. She was on Lasix as well. I am always shocked by that kind of thing, but sometimes it is by a cause that we're not thinking about, and it can be reversed, which is a huge deal to anybody. If you're thinking about sitting in this class right now wearing an incontinence brief, I can't imagine. Or just not being able to control it so much, or that it's painful. These people are going through that every day. Antimuscarinic medication is a class of medications that may cause cognitive impairment in older adults. So it is important to evaluate their mental status closely to watch for any changes, especially the new ones, Vesicare, things like that are just getting on the market. They may cause your patients to be confused, and that's kind of have to weigh the pros and cons. Would they rather be continent or function cognitively? Impaired mobility and incontinence are cause for an intervention of the patient to maximize self-care and continence. Teach older women pelvic muscle exercises, effective for all ages, really. Your sensation of thirst also decreases with age. Remind older adults to drink sufficient amounts of water to promote bladder health, or anything non-caffeinated if they're not water drinkers. Instruct patients to avoid fluid intake 2 hours prior to bedtime to decrease nocturia, which is urinating during the night. And retention can occur from age-related prostate enlargement in older men, so be sure to assess when there are changes in voiding pattern. And I've learned from many years in nursing that older men are not going to tell you that they have a problem urinating. They kind of just think it's a process of old age, and they've just learned to cope with it because it onsets gradually. So sometimes you have to ask those uncomfortable questions, along with when was your last bowel movement and what did it look like. You also have to say, what is your strain like? Are you urinating a lot at one time? Are you urinating more at night? Because it might be something that's really limiting their capability and giving them trouble psychosocially too. The psychosocial implications. Self-concept, culture, and sexuality are all affected when elimination problems occur. Your self-concept includes body image, self-esteem, roles, and your identity. When children start to learn appropriate toileting skills, they sometimes associate their urine and feces as part of them and do not want to flush them away. Some of you will be working with pediatrics at some point. If anybody's potty trained a child, they know this does happen. Micturition is often a culturally private process and requires a need for privacy. I lived in Japan for a short period of time, and they urinate by squatting over troughs in the Japanese bathrooms. And a lot of times there's no stalls or anything. It's just a bunch of women squatting over troughs. I was like, I'd rather go out in the woods. But it is different in different places. So you're going to have patients of different cultures. You've got to kind of expect that things are going to be different from them. I just let the patient kind of lead me. Because it is an awkward situation until you learn to deal with it. Incontinence may damage self-esteem and your self-image. When a patient asks for help, it can be embarrassing or may threaten their sense of self-determination. You just have to be really gentle with them. Don't make them feel bad for it or roll your eyes and sigh because you have to clean up another mess. Just, it's part of what we do. Your shift will be over at some point, and the next one will be better. A urinary diversion, for example, in a nephrostomy tube or a urostomy bag, might influence a patient's sense of body image, which can result in inability to maintain healthy sexual relationships. It would be extremely uncomfortable to deal with that and still have a husband that you wanted to be, intimate with, or wife. Or as a nurse, always be aware of these affects and understand your role in their occurrences. I'm sure you guys will do well with it. Common urinary elimination problems involving inability to store urine or fully empty the urine from your bladder are the most common, and there are medications for that. Causes can range from infection, irritable or overactive bladder, drinking too much coffee, obstruction of urine flow, impaired bladder, contractility, or issues that impair innervation to the bladder. Retention is the inability to partially or completely empty the bladder. Retention stretches the bladder, causing feelings such as pressure, pain, discomfort, tenderness over your symphysis pubis, restlessness, diaphoresis, confusion. Several hours of no urine output can cause patients to experience frequency, urgency, small volume voiding, and incontinence of small amounts of urine. You'll see frequently a doctor will order a PVR, post-void residual, because they suspect that this is going on with a patient. And so it's important not to just take a random one. I've seen some nurses do it. You really want the patient to stand or sit to void, get back in the bed, lay down, and get a really complete post-void residual with a bladder scanner to see exactly what they're retaining after they void. A lot of people will be filling their bladder to, 1,000 cc's and then just getting off that extra pressure of 50 or 100 cc's every time they void. And that's really uncomfortable. I cathed somebody once and got 4,000 cc's on it. We had to keep blocking it off and do it in little amounts, but he was a chronic retainer from prostate issues. Several hours of, I did say that. Okay, chronic urinary retention has a slow, gradual onset in which patients may experience things like decrease in voiding volume, straining to void, frequency, urgency, incontinence, sensations of incomplete emptying, and that was this gentleman that I catheterized like that. His bladder did not just overnight hold 4,000 cc's of urine. This was a process over years where your tissues there have to stretch to be able to hold that much. The post-void residual I told you about. Overflow incontinence is what that's called when you're just putting out 50 or 100 cc's on top of the 4,000 that this guy was holding. The patient will dribble urine if the pressure in the bladder exceeds the ability of the sphincter. Then urinary tract infections are the most common healthcare-acquired infections. Almost all are from instrumentation of the urinary tract. E. coli is a bacterium commonly found in the colon and is the most common causative pathogen. You can imagine why. This is from women who wipe from back to front. This is from people who are wearing adult briefs, which are the devil in the healthcare system, but they are incontinent of stool and it's pressing right up against their urethra and it's causing bacterial infection. And E. coli is an awful thing to have in your bladder or your ureters. An indwelling catheter, any instrumentation of the urinary tract, scopes, things like that, urinary and fecal incontinence, urinary retention, and poor perineal hygiene. UTIs are characterized by location. If they're upper UTIs, they're in the kidney, and if they're lower, they involve the bladder and urethra. Bacteriuria, or bacteria in the urine, does not always indicate the presence of a UTI. Some people carry bacteria naturally in their bladder, especially older people. And if they're having no symptoms, a lot of times you'll see that the physician will not treat. A lot of the physicians I've worked with will look at the urinalysis and say, okay, they have positive leukocytes in their urine, but their WBCs are negative. So we're going to just consider that either contaminated or that's their natural flora coming through on the urinalysis, and we're not going to prescribe an antibiotic for that and subject them to all the other side effects of that. Symptomatic infection, untreated by antibiotic, can lead to serious upper UTI, pyelonephritis, which is unbelievably painful for a patient, and potentially fatal bloodstream infections. That bacteria can easily travel, if it's untreated, into your bloodstream and cause sepsis. I see urosepsis in the hospital quite a bit, and it is occasionally fatal. Symptoms of lower UTI can include pain and burning with urination, dysuria, and that's more, you can tell by where their pain is, where their infection is. If they're having back pain, a lot of times it's kidney. And then at the meatus, it's going to be your urethritis. Irritation of the bladder, cystitis, urinary or urgency, frequency, and incontinence. Suprapubic tenderness, which is easy to assess. If you press a little bit, they'll yell out in pain. And then foul-smelling, cloudy urine. Be prepared, because I have catheterized people and seen stuff that looks like thick, curdled chocolate milk. But, those are the people that really need your help. That's why we focus so much in your skills on inserting urinary catheters with aseptic technique. because we don't want to introduce anything more than what's naturally going to be, put in there. In some cases, there is obvious blood in the urine. If pyelonephritis occurs, patients may also experience fever, chills, diaphoresis, and flank pain. And then they get urine around the kidneys and everything gets blocked up. And then so that infection is spread to that area and it's going to be a longer treatment. CAUTIs are an ongoing problem for hospitals, catheter-associated UTIs, because their association with increased hospitalization, increased morbidity and mortality, longer hospital stays, and increased costs. October 1st, 2008, the CMS chose CAUTIs as one of the complications for which hospitals no longer receive additional payment for the extra cost of treatment. And unfortunately, CMS had to do this kind of a thing because these things were naturally occurring and so frequently, or not naturally, but they were occurring so frequently in the healthcare system that they were costing CMS a fortune, and anything that they tried to eradicate these occurrences was not seeming to work, so they had to pull their funds from hospitals and say, you give somebody a catheter-associated urinary tract infection, you're covering the rest of their stay, because we're no longer involved. So that's why hospitals are so concerned now with catheter care every 8 hours, all of this, and getting a urine culture so they can be treated with the right antibiotic. Urine sampling for a microbiological workup must be done with caution to avoid contamination for that same reason. We want to make sure that we're not extending their stay with the wrong antibiotics. For critically ill patients, sampling should be done either routinely once a week or at the start of a new episode of sepsis. CAUTIs are usually deemed present at a minimum of 10 to the third colony-forming units, or of 1 or 2 microorganisms are identified by urine culture. If you get multiple specimens in a urine culture, it's probably not a clean specimen, and you're going to subject them to the wrong antibiotics, and they're going to get sicker. Urinary incontinence, defined as the complaint of any involuntary loss of urine. Common problems that affects a wide variety of people, including over 70% of nursing home patients. Some common forms of urinary incontinence are urgency urinary incontinence, involuntary leakage associated with urgency. They just can't get there fast enough. Stress incontinence, when they're coughing, especially people who've got pneumonia are going to have this problem. They won't always tell you either, especially if they're a younger person. Mixed urinary incontinence, when both of those types are present, and overflow, leakage from the overflow bladder, and functional incontinence caused by factors that interfere with the patient's access to the toilet or other acceptable receptacle for urine. I always think of this one as those of us that have had lots of children and try to run. Sometimes they have that problem. A more recently identified category is the multifactorial incontinence, which possesses multiple interacting risk factors, some with the urinary tract and some not. Then you have your diversions. Patients that have gone through a cystectomy where they've removed the bladder may require surgical procedures to divert urine outside of the body through a stoma, an opening in the abdomen wall, which is similar to your colostomy, your ileostomy. They'll have a urostomy with a bag attached, and sometimes another catheter tubing and another bag attached to that, because sometimes they put out quite a bit of urine. The urinary diversions are constructed from a section of intestine to create a storage reservoir for the urine. Diversions can be permanent or temporary, as well as continent or incontinent. There are 2 types of continent urinary diversions. Your continent urinary reservoir, made from a distal part of the ileum and proximal part of the colon. Ureters are embedded into the reservoir, and the reservoir is under the abdominal wall with a narrow ileal segment brought out through the abdominal wall to form a small stoma. The ileocecal valve creates a one-way valve in the pouch through which a catheter is inserted through the stoma to empty the urine from the pouch. So the patient is going to catheterize themselves 4 to 6 times a day for the rest of their lives. Then you also have an orthotopic neobladder. Uses an ileal pouch to replace the bladder, allowing the patient to void through the urethra using a Valsalva technique. So a lot of times you're going to have patients like in a rehab situation or a post-op situation, and you're going to be teaching them hygiene with these. It is so important because we see these come in a lot of times with urinary tract infections because they're not using a clean catheter every time. They're not sterilizing everything that they need to. They're going a long time without emptying that pouch for the incontinent ones. And then they have this cloudy, nasty urine. So if you see them doing something like rinsing it out with a paper towel from the bottom or something, please, just gently instruct them not to do so. Especially those that have had it for a long time, they've created shortcuts that cause them a lot of damage. A ureterostomy, permanent IUD, created by transplanting the ureters into a closed-off part of the intestinal ileum and bringing the other end out onto the abdominal wall, forming a stoma. The patient has no feeling or control over the flow of urine through the ileal conduit, requiring the need for a pouch. So this person is not going to be catheterizing themselves. They're just going to have a constant dribble of urine through the stoma. Nephrostomy tubes are small tubes that tunnel through the skin into the renal pelvis. They're used to drain the renal pelvis when the ureter is obstructed. They're usually on the flank, left or right, sometimes both, and they're usually attached to a smaller pouch that you have to drain frequently. It is important to thoroughly teach your patient about site care and signs of infection before sending them home. And make sure they teach it back to you. Sometimes they'll nod their head and pretend that they're listening to you, like some of you are probably doing now because I'm so fascinating. But just make sure if they can explain it back to you, that's the best way to know that you've gotten through. Men may have stress incontinence after prostate surgery due to the trauma of the urinary sphincter because they're going up with that transurethral resection of the prostate. People with high caffeine intake may experience increased urinary urgency and frequency. I've had 3 pots a day for the last 5 years. Not affecting me at all. Use attitudes like perseverance when finding a successful management plan for urinary elimination problems. Patient assessment. There are many factors to consider when assessing a patient. Always approach your patient in a professional manner and assure confidentiality so they feel comfortable discussing their symptoms. Sometimes with people who are uncomfortable talking about this, you may have to sit down and get on their level and actually address them. At the same height makes a patient feel like you are one of them, that you're not a person in a position of power that's telling them what to do. Start by assessing the patient's own knowledge and understanding of their urinary problem. Some people will tell you some crazy wives' tales or things like that you'll be like, okay, well, let's talk about what the evidence shows. It is one of the many responsibilities of a nurse to educate their patients to the best of their ability, ensure they are aware of all possible side effects, treatments, etc. Other factors to keep in mind include the patient's ability to care for themselves, cultural considerations, like their privacy, how they feel, their urination should be handled, and the patient's health literacy. One thing I know from personal experience, my in-laws are all from a third world country. And if you visit their restroom, you don't ever want to visit their restroom. They don't have a lot of money, and they use their own personal rags to clean themselves after going to the bathroom. And they're all hung on a thing next to the toilet, next to each other. Everybody knows whose rags is who, and they don't use toilet paper. So we try to empty our bladders before we get there and make plenty of trips out so we can use the public restroom. It's just people are different everywhere you go. As well as the above stated, you must also perform physical assessments on your patients and assessments of the urine. So you're going to be looking at the color of the urine, clarity of the urine, whether or not there's sediment, there's blood, how often a patient is going, how much they're putting out, things like this. And you have to kind of get with your nurse's assistant at the beginning of your shift and make sure you're clear on who's doing what, because intake and output are very important. Sometimes the nurse's assistant thinks you're going to be emptying things. You think they're going to be emptying things. You think they've documented or you've documented. As long as you're just clear with them at the beginning of the shift, things will go a lot smoother and be a lot more accurate. A thorough assessment of the patient's ability to perform necessary behaviors associated with voiding is important. If you're going to get a urinalysis and a urine culture from an 84-year-old woman and you're teaching her how to do a clean catch, you need to watch her pretty much, unless she absolutely refuses. Nowadays, a lot of places you go, they'll require a catheter from even a continent person of my age because you just don't know if they are understanding what you're saying and able to do it without being embarrassed to tell you that they're not. It's often challenging to balance patient safety and the support of self-care, so be sure to discuss with your patient and establish what they are able to do on their own and what they might need assistance with. Again, be sure to make your patients feel comfortable so that you're able to gather all the necessary information. We have a professional attitude that we have to keep, and we have to kind of remain distant from our patients. But a lot of times those that are uncomfortable and feel like they can't talk to you, I use a story of my own. I'm just like, yeah, I've had a catheter before. It's painful. I had problems afterwards. What are you feeling? Like, are you able to go? Are you having the urge to go? Things like that. And it seems to help them feel a little bit more comfortable. I wouldn't get into a whole lot of personal information, but just that story, like, I've been through this, I can help you. Helps a lot of the time. Especially with younger people, like teenagers, they're so, I don't know, it's almost like they see you as a parent type person who's out to get them sometimes. Be sensitive and ask your questions in a straightforward manner. I tend to use the word potty a lot, so I have to kind of correct myself. Be like, I'm sorry, I'm a mom. Urinated. Be aware of gender differences. Men stand to void, whereas women sit, usually. Gender-linked urinary alterations, such as prostate enlargement in men and pelvic organ prolapse in women. Have any of you guys ever seen a vaginal prolapse or a rectal prolapse? Things like that, yeah. And they're very self-conscious of these things, so it can lead to the inability to void, things like that, or bacterial involvement in urination. In some cultures, it may be inappropriate for a male to discuss elimination matters with a woman. It is important to be respectful of this and provide care accordingly. Just explain to them what your goal in this care is, that we're just here to treat you. I don't care personally how your urination is. I'm not here to judge you for that. I just want to make sure that you're healthy. In other cultures, the cutting of female genitalia is practiced, which can be severe and include long-term consequences such as recurrent UTIs, pelvic function, scarring, incontinence, fistulas, and sexual dysfunction. And fistulas, I've seen where they'll get stool coming through the bladder constantly, and occasionally they can't be repaired because the tissue is so frail. Health literacy. Be careful to assess the patient's understanding of his or her own anatomy, as well as the understanding of urinary tract problem and the terminology involved. Try to use words that they're going to understand. Potty is pretty much something that people do understand, but they kind of laugh at. They don't take me seriously. But if you use things like urethra and meatus and things like that, and they kind of stare through you, you know that you're not getting through. The doctor is really bad about this. You have to kind of witness what the doctor says to the patient and then come back and be like, so what he meant was, you understand me, right? And make sure that they get it. Lack of knowledge in basic anatomy and urinary tract functions can contribute to poor outcomes of treatment. You don't want the patient coming back because it just plain didn't understand what you said. Nursing history includes a review of the patient's eliminary patterns, the symptoms of urinary alterations, the assessment of factors that are affecting the ability to urinate normally. Some examples of nursing assessment questions to ask that may help direct the patient to focus on the urinary problems are, which problems are you having with passing urine? Are you going too often? Are you going not enough? Does it burn? Signs and symptoms. Does it burn? Do you dribble before you void? Onset and duration, how long has the problem lasted? To find out if it's an acute or chronic problem is important. Severity, how many times do you urinate in a day? How often do you wake up to urinate at night? Predisposing factors, what is your typical diet fluid intake, and are you on daily medications such as hydrochlorothiazide or Lasix, things like that that are going to make you have urgency and frequency? And the effect on the patients. How have they affected your life? Your quality of life is important. Pattern of urination. Ask the patient about the daily voiding patterns, including frequency and times a day, normal volume at each voiding, frequency, fluid intake, common times. A lot of people go at the same time every day. If those change, we need to know. Waking at night. It is important to establish what is normal in order to be able to compare when assessing a patient what is going on now compared to what usually goes on. Then there's some terms you need to know and Symptoms that'll be important. We've pretty much discussed them all. Polyuria, avoiding excessive amounts of urine. You've got oliguria, diminished urinary output. You're going to see that a lot in chronic kidney patients. Even acute kidney injuries can do that. We'll have to give them, 4 liters of saline before they start putting out urine. Nocturia, dribbling, hematuria, blood in the urine, retention, holding back some urine. Primary areas to assess in your physical assessment include the kidneys, which you can palpate. I think you've got some stuff when you practice your skills that teaches you that, or if not, it'll be in second year, where you can tell if a patient has tenderness, where your kidneys are going to be inflamed, then they're having some kidney involvement that's abnormal. Bladder, like I said, you can feel above the symphysis pubis to tell if it's extended, and if it's distended. External genitalia, you have to take a look sometimes. If they're having pain at the meatus, you need to know if they've got a fungal infection going on there. It's not always comfortable. Get their permission first, and a lot of times you need a witness just to make sure that nobody ever accuses you of being inappropriate. And then the perineal skin to see if they've had some incontinence. Fluid intake and patterns can provide additional objective data. When examining the kidneys, tenderness is a result of infection or inflammation. Assess for tenderness by gently percussing the costovertebral angle, which is formed by the spine and the 12th rib. That's where it's going to be the most tender. An advanced practice nurse might perform auscultation to detect the presence of a renal artery bruit, and it's a sound resulting from a turbulent blood flow through a narrowed artery. Just kind of like you hear if you guys have assessed a fistula or a graft for a kidney patient. Sounds similar to that bruit. When examining the bladder, a very full bladder might rise above the symphysis pubis, extending as far as the umbilicus. So, if you get tenderness, you can kind of climb up and assess. If they're painful up to the umbilicus, then they've really got a distended, painful bladder, and they need to be seen ASAP by the physician. You may observe swelling or convex curvature of the lower abdomen on a thin patient. On gentle palpation of the lower abdomen, a full bladder may be felt as a smooth and rounded mass. During palpation, patients may feel a sensation of urinary urge, tenderness, or possible pain. If an overfull bladder is suspected, further assess with an ultrasound device or bladder scanner. When examining external genitalia and urethral meatus, inspection of these areas yields important data that may indicate inflammation or infection. And there's some explanations here and in your book on how you would perform that on a female or a male. Patients with indwelling catheters should have urinary meatus assessed for catheter-related damage caused by pulling and traction on catheters. Some severe cases involve the catheter eroding through, and you'll see that in a male that's had catheters frequently or for a long time. The actual opening in the head of the penis will be split from one side to the other. So, that's why they have the stabilization devices. So these things aren't getting pulled on routinely and causing permanent damage. And then once that happens, they tend to leak around the catheter a lot because there's all this chronic damage. When examining perineal skin exposed to moisture such as urine should be assessed at least daily, at least shiftly. More so if incontinence is ongoing. Observe for erythema in these moisture-exposed areas. Also observe for skin erosion and complaints from patients of burning, itching, pain. A lot of times you'll see what we call maceration, which is chronic exposure to this urine held against the skin, and the skin will be sort of a pinkish color and can look like hamburger meat. It's just constant damage from urine. So you're going to want to put on a protective, get everything really clean and dry and put on a protective barrier of some sort. All facilities have their preferred product. And even when you're in a hurry and you just want to get out of there and you put the moisture barrier on the last time, just please do it for the patient. It takes 2 seconds. Just get your gloves dirty and be done with it. Assessment of the urine. This involves measuring the patient's fluid intake and urinary output and observing the characteristics of the urine. Assessing INO is a way to evaluate bladder emptying, renal function, and fluid and electrolyte balance. They need to include everything that's liquid. And then, like I said, just keep up with your CNA or whoever's helping you and make sure that everything is documented so you have an adequate picture of what's going on. And it talks about the urine measuring receptacles. If any of you have a way to figure out how to make these without invisible numbers on them, you could be a billionaire, because it is so hard to see those things on the urinals, little plastic urinals, on the hats, all of that. Well, actually, hats now have black numbers usually, but you've got to, yeah, exactly.
120 mils off.
Right. And then so you've got this invisible thing that you're trying to measure at eye height, which is another risk for spilling the darn thing on yourself. You know, it'd be nice if we had like rainbow colored national, the same colors, like red is for 200 cc's, orange is for 300 cc's, but I guess it's a cost thing. So let's see. Characteristics must be monitored. Any change is a concern. The normal color of urine is between a pale straw color and amber, depending on the concentration. A lot of times medications will make it a different color. Methylene blue, if you ever have to give it. They only really use that now in severe urine surgeries where they can see if things are leaking, but it'll turn your urine a bright green or a bright blue. You know, if you know they're on that medicine, it's going to be a lot less concerning when you see it. It's usually more concentrated in the morning or with fluid volume deficits. That's why they tell pregnant women when they want to take that test and they're early on in their pregnancy to see if it's positive, do it in the morning because you've got the most concentrated urine and you've also got, you know, more coming out, more waste products. Bleeding from the kidneys or ureters usually results in dark red urine. Hematuria, while bleeding from the bladder or urethra, can cause bright red urine. Hematuria and blood clots are a common cause of catheter blockage, where you'll be thinking about doing some irrigation. And then you will be seeing, especially if you do your clinicals at OMC on their medical surgical floor, you're going to see a lot of CBIs, continuous bladder irrigations. They're kind of interesting because there's no real like measurements as to how much saline or sterile water that you're putting in. And it's really the nurse's judgment and constant monitoring that's going to tell. We're irrigating this person's bladder, usually after a TURP, transurethral prostate resection, backwards. But you want it to be like a light watermelon color, and you have to keep monitoring and just using the roller clamp that got IV tubing to adjust that flow to where you're getting the normal output. Sometimes this patient is going to put out 8,000 cc's of urine in 4 hours, so you got to be ready to be in there every hour to monitor. But it's a great thing, you know, to keep them from clotting up, and you have to hand irrigate all the time. But you're going to find if you don't pay attention, you're going to be hand irrigating, and you're going to pay a lot more attention later because hand irrigating is a disgusting, messy process, and it's painful for the patient. The kidneys excrete special dyes used in IV diagnostic studies. This causes urine discoloration. Dark amber urine is a result of high concentrations of bilirubin in patients with liver disease. And I noticed when you have bilirubin in your urine, it's a distinct color. It's like an orangish, brownish color, and it seems like it sticks to whatever you put to measure in. So if you notice that there's kind of a stickier urine, and it's a different color, you want to look at your patient's liver functions. Do you guys need a quick break? Oh, everybody okay? You can take one during if you need to. Other discolorations are most often results of diet and medications. Clarity is going to be how clear it is. It usually appears transparent unless having sat in a container for several minutes, resulting in a more cloudy appearance. It's going to separate based on the specific gravity when you see it in water, in the toilet, or in a measuring thing. Freshly voided urine can appear cloudy in patients with renal disease because of the protein. Also, if a patient's urinating in a urinal, I can tell when they've got proteinuria because they'll have like a big head of foam on top of their urine. You can tell, ooh, maybe this patient needs a urinalysis. Urine also could appear thick and cloudy as a result of bacteria. and white blood cells, and very stinky. The characteristic smell of urine is ammonia. That's what you're smelling. You can smell urine. The more concentrated the urine, the stronger the smell. Those of you who have a really sensitive nose you're gonna find these things a lot faster than other people. I have an amazing sense of smell. I don't know if it's a gift in this profession or not, but it's not going away. Some foods can cause a change of odor. Asparagus, because asparagus like completely cleans things out of your bladder. It comes out smelling, your urine will smell like asparagus. Some foul odors will indicate a UTI. As urine remains sitting in a container over time, some ammonia breakdown occurs, making the odor even stronger. That's what old urine on you can tell if a patient hasn't been changed in a long time because it is nasty. For lab and diagnostic testing, as a nurse, you're often responsible for collecting urine specimens for testing. The type of test determines the method of collection, and it's important to follow procedures accurately. If your physician has just ordered a random urine sodium or a random urine potassium, things like that, they'll want to know. Creatinine is something that they'll order to find out exactly what's going on in your kidneys and bladder function. You don't have to do an absolute clean catch catheterized urine. Don't subject your patient to that. It is random, and it is for creatinine. They don't care if there's bacteria in it or not. A lot of times, though, they're going to order that with a urinalysis, which has got to be clean. Most urine specimens, I don't know why I'm putting a T on the end of every word. They're required to reach the lab within 2 hours of collection unless preserved according to lab protocol. Urine left at room temperature will grow bacteria, which affects the accuracy of the results. I sent down a urine specimen the other night at the place I work in Auburn, and they accidentally canceled some of the tests on it. They did the urinalysis, but they didn't do the random creatinine or random sodium. And so I called like an hour later, and I'm like, where is this test? And they're like, oh, it got canceled. And I'm like, well, I can see it on my end. It's still here. And I had catheterized the patient for the urine sample. They were totally incontinent. And they said, well, we didn't do the sodium or the creatinine. It got canceled. You need to reorder it. And then you better just recollect it, because the one we have sitting here in the refrigerator is probably not going to be accurate. I'm like, no, it's accurate. I want you to run that urine because I don't want to do it again. And they absolutely refused to do it. So they've got now, it was crappy on my part. I should have just gotten a urine sample because it didn't need to be clean. I could have just gotten it on a bedpan or something. But, I didn't want to put the patient through that at 3 or 4 o'clock in the morning. So nowadays, though, they have lab procedures where they absolutely will not take it if it's an 84-year-old clean catch woman and it shows up that it's got skin cells in it. They'll send it back and be like, I'm sorry, we're not running this. You need to do something else. Which is awesome. It's, like us double checking a pharmacy's order or a medication order, they're the last check in that system. Sometimes a midstream clean catch urine specimen might be necessary to collect urine with as little contamination as possible, but a lot of times you're going to end up catheterizing. Collection type, use of specimen. There's some tables here. It tells you when and how to do things that they're going to want. Normal measurements on a routine urinalysis, your pH. If your pH is off, 4.6 to 8 seems very broad. A lot of times if it's high on that spectrum or low on that spectrum, even though it falls in normal value, you're going to suspect acidosis or alkalosis and something's going on with the patient. Acid pH helps protect against bacterial growth. So they say, I don't know if that's in here or not, we were talking about cranberry juice. Drinking cranberry juice somehow affects the pH of your urine. It'll keep it a little more acidic. So if you start feeling symptoms of a urinary tract infection, you can try to be proactive and drink a bunch of cranberry juice. Try to see if you can protect your bladder from the oncoming onslaught of bacteria. Glucose is not normally present. You'll get labs calling you with critical glucoses in urine. There's nothing you can really do in the middle of the night about a critical glucose in the urine. Your patient's probably going to be diabetic, DKA, things like that. They're already going to be treated for that glucose. But it, is good to know that they're passing through a bunch of sugar because they're overloaded. Ketones can be a sign of people with poor control of their diabetes or people that are having metabolic issues and not absorbing their nutrients. Going on a ketogenic diet, a lot of times you're going to have ketones in your urine. That's your body's way of saying something is not quite right, but I guess ultimately those people are trying to get in that metabolic state. Blood in your urine can be from kidney problems because blood doesn't normally come through those glomerular tubes. Specific gravity, that's going to tell you how much your urine weighs pretty much. And the concentration of particles in your urine can tell if you're dehydrated. Microscopic examination of RBCs. A lot of times when you cast somebody, you will cause a little bit of trauma and it's going to show some RBCs. I always feel kind of guilty about that when I cast babies. But if there's just a tiny bit, you can sometimes attribute it to that trauma and just assess afterwards and make sure that they're not having symptoms of blockage or infection. If it burns, then consider that you've caused a little bit of trauma. You may cause an infection because you've got that open spot there. Damage to glomeruli or tubules allows RBCs to enter the urine. Trauma, disease, presence of urethral catheters, or surgery of the lower urinary tract can cause that to come out in urinalysis. Your WBCs, inflammation or infection, and bacteria that's not normally present in a urinalysis can mean infection or colonization if the patient shows no symptoms. That's a big, bad, nasty infection. Casts are cylindrical bodies. They typically include hyaline, WBCs, RBCs, granular cells, and epithelial cells, which are usually skin, but they can come out in the presence of renal disease. And then crystals are presence of a stone usually, or the possibility of having one later on. And a lot of times they'll test those to see what they're made of, because uric acid can be a symptom of gout. You'll see that sometimes, random uric level in a urine specimen to find out if they've got gout. Diagnostic examinations. The urinary system is one of the few organ systems accessible to accurate diagnostic study by radiographic techniques. Studies can be simple and non-invasive or complex and invasive. We're always going to be going for the simple non-invasive first. Non-invasive procedures can include an abdominal röntgenogram, computerized axial tomography, or CT scan or ultrasound. An example of an invasive procedure would be the endoscopy or cystoscopy. I've actually helped with a cystoscopy in a male patient, and the tubing that they insert in there, they can do it right at the bedside. You have to just keep your physician in sterile and assist going in there. The tubing is unbelievably long that they stick in there to scope. So it's invading every spot that it's going through and almost always going to cause some type of an infection and definitely some pain. I've also helped pull out a stent in a ureter, and literally the tubing, I had to grab it with the little clippers while he pulled the tubing out, and he was looking through the scope at the same time, and that tubing was literally probably 3.5 feet long. I don't know how in the world. It was like he was going into the mouth, but everything you put inside of that system is going to cause trauma and going to cause a potential for infection. Let's see. The cystoscopy. Some responsibilities of the nurse before testing are to ensure the signed consent is completed. That's going to be the nurse that's actually contributing to the procedure. A lot of physicians are going to ask you to get a consent signed on a patient's chart when you're the inpatient medical surgical nurse and you're there overnight and the patient's going to have the procedure in the morning. And really, I think legally, you cannot have a patient sign that unless they absolutely understand the process and the physician has explained it to them. So you're totally allowed to say, I'm going to put that consent form on the chart. You can get the patient to sign it in the morning because your witness to that says that that physician has explained that procedure to the patient. So if they haven't done it in front of you, you don't have to provide that for them. They just want it because it's easier for them to have it completed before the surgery. It's one of their check boxes. To assess the patient for allergies, previous reaction to contrast agent. A lot of people don't know that they're allergic to contrast dye until they get the contrast dye, and then they have a reaction. Sometimes they can have some shortness of breath, a lot of anxiety. Be prepared to give some Benadryl and things like that. If they've got an IV contrast, they're going to have an IV that's big and in a local spot where you can get things in fast. Administer bowel cleansing agents as ordered. Sometimes they want the bowel empty to do certain tests. Ensure patient adheres to appropriate pre-test diet. They'll want them a lot of times to restrict caffeine and things like that because that'll be a bladder irritant. Some responsibilities of the nurse after the testing are to assess intake and output, assess the urine for color clarity and dysuria, and to include fluid intake, especially if using a radiopaque dye, and especially if they've got some kidney compromise. A thorough assessment will reveal patterns and data that allow a nurse to make accurate nursing diagnoses. Use critical thinking to reflect on knowledge of past patients. That is your best experience as a nurse. Things that you've seen in the past, you'll see symptoms of in the future that you can be like, whoa, I remember when David Jones had that problem and I had no idea, and now I can act a little bit faster to take care of what's going on with Tom Smith. Apply knowledge of urinary function and effects of the disorders, which I know you guys are getting hammered into your head over and over with anatomy and physiology, with microbiology, with now your, all these fundamental courses and things like that. But the reason for that is because the more you hear it, the more it's going to come up in the back of your head when you see something that's abnormal, and you're going to go, I know exactly what to do. Even though I'm a new nurse, I have all of this knowledge that I can apply to the situation. Review defining characteristics, make a specific nursing diagnosis. Identification of risk factors leads to section of a risk diagnosis. In this case, you select correct risk factors and select interventions that treat or modify the related factor or risk factor. If any of you are thinking about working in the emergency room or critical, be like first responder type situations, you're going to need to know what these symptoms are very quickly, and a lot of times you're going to intervene before the physician actually tells you to, because they'll be in a standing order saying, this is what we're going to do if a patient comes in and they haven't voided in 8 hours. We don't have a bladder scanner. We're just going to put in a catheter. Those things are kind of going away with catheters. But, you're going to have to know your physician, what they typically order. You're going to get a urine sample before they order it, things like that, so that you can speed up the process of that patient getting care. So there's more of us than there is of them usually. A few common diagnoses of patients with urinary elimination problems. There's functional urinary incontinence, stress incontinence, urge incontinence, risk for infection, toileting self-care deficit. We've talked about those. Planning. Combine what was learned from the assessment and the information on available resources and therapies to devise an individualized plan of care. Everybody is different, but we need to take the information that we have and build something that's going to work for them. It is important to build a sense of trust between you and the patient because this is a very personal process. Goals and outcomes. Nurse and patient must collaborate in setting goals and outcomes and ultimately choosing nursing interventions. The ultimate goal is normal urinary elimination, but the patient's individual goals may differ depending on the problem. If they have a neurogenic bladder, the goal is going to be to teach them how to do self-cathing or to teach them how to do Foley catheter care, things like that. Be sure to set goals and outcomes that are reasonably achievable and relevant to the patient's situation. This is where case management is extremely helpful. A lot of times, patients in certain situations, I worked at a place in Eastern Washington where they actually had home visits before they would let the patients go home after rehab. And they'd have a team of people go out and make sure that these people had handicapped access to the toilet or, some kind of bedside commode that they could get to in the night if they had really bad nocturia. Made sure that they could actually change their briefs and do actual hygiene so that the patient wasn't being readmitted with the same problem in a little while. And if they failed the home visit, they weren't ready to go home. So we had to, as nurses, take care of, getting them situated so that they could rehab a little bit more and go home. Teamwork and collaboration. Planning individualized care requires the expertise of the nurse as well as the healthcare team as a whole. Respect what everybody in this situation has to say. That is one of the biggest problems in nursing and healthcare in general, is that we don't talk to each other very nicely. sometimes we'll pretend we respect each other and we'll turn around and be like, nah, I don't care what he says. This patient is fine. I'm going to get a clean catch on that old lady. I don't care. Everybody has a different perspective. With multiple factors and processes to consider, it takes multiple caregivers and specialists working towards the best possible outcome of a single patient. I have a sister who's a registered dietitian. She just got her diabetes educator certification. And we collaborate a lot on certain things, you know, not giving any patient information to each other, but being like, I'll tell her things. I had this patient that, you know, this was going on, and I think he was maybe impaired electrolyte-wise, and what's going on there? And she can feed back to me what she knows, being a dietitian, just part of the healthcare team, and also ask me things like that too. This patient was in this situation. What does that mean to you? And it certainly helps if we could just look at that through that kind of perspective towards everybody that's involved in taking care of that patient. It would go a long ways towards their better outcomes. Health promotion through patient education. Success of therapy aimed at eliminating or minimizing urinary elimination problems depends in part on successful patient education. Like I said, teach them these things that are important and then have them teach them back to you. Promoting normal nutrition. Sometimes we'll do things that things from old times come back. We do bladder training in people with catheters sometimes. If they've had a catheter for a long time, those muscles are no longer going to keep that patient continent and voiding appropriately. So they'll do things like they'll clamp off the Foley catheter tubing for long enough that the bladder fills, those muscles distend, and then they can feel the urge to contract. And that'll sometimes tell you if the patient is ready to have that catheter taken out. And they can do that for a long period of time, keep it clamped for a couple of hours, and then let it out. So it's kind of more the normal flow of the bladder to train that bladder into functioning correctly. We did that many years ago, and then we stopped doing it because we thought it was maybe causing bacterial infection. But now I see it coming back just on a shorter period of time. Try not to fill the bladder and leave it there for 8 hours. Make suggestions to the patient accordingly, such as scheduling extra fluids or eating high fluid foods like fruits. A lot of people come in and they'll tell you, like, church is their everything. They're not going to drink a bunch of fluid before they go to church. They're also never going to take their Lasix before they go to church. And some people are in church all day Sunday. Find these things out, you know, make sure that they're doing things that are going to keep them out of the hospital as much as possible. Health promotion through promoting complete bladder emptying. While it is normal for a small amount of urine to remain in the bladder after micturition, if residual urine volumes are high, there could be risk for incontinence and dangerous urinary retention. And we pretty much talked to that. But one way to promote relaxation and stimulate bladder contractions is to help patients assume the normal position for voiding. If you're going to get a post-void residual on a patient who's just had a hip replacement and they're not able to get out of bed, it's appropriate for you to let them go on a bedpan. But if there's any way that you could get that patient out of bed, even with the help of three other nurses, you want to get them up to the normal position that they're going to be urinating in, because, you know, gravity helps most of the time. There's a reason that we do sit in that position or stand in that position to empty our bladders. And that's going to be the most effective way to get things going on in normal routine. Do not implement manual compression of the bladder until discussed with the healthcare provider. So you can definitely assess for tenderness, just very light touching of the patient's abdomen. But if you are going to press really deep palpation, you want to make sure that the physician wants you to do that first, because there are certain instances where, like the gentleman that I catheterized that had a 4,000 cc bladder, if that was somebody with an acute problem, you could potentially rupture their bladder or cause some damage there. And then they talk about intermittent catheterization. People that are having trouble urinating, they now, instead of just directly putting in a Foley catheter or an indwelling catheter, they want us to do some intermittent catheterization. Just keep in mind that every single time you enter that bladder, you're potentially exposing that patient to bacterial infection. And the reason for that is anything left in that bladder is a constant invasive material that can gather bacteria. And then also a patient may just be having an acute reason that they're not voiding. So maybe if you've catheterized them once, then that normal elimination will occur. Sometimes it takes 3 times, you never know. Some key interventions include adequate fluid intake, promoting perineal hygiene, encouraging patients to void at regular intervals, encourage women to wipe front to back and avoid perineal washes, bubble baths, and tight clothing. Hygiene should especially be stressed when dealing with patients that have urinary leakage problems. And it is uncomfortable to talk about these things with your patients. You just have to kind of work through that. Practice it in the mirror if you have to. You know, if you find yourself having trouble talking to people, don't avoid it. I've seen that a lot. People will avoid what makes them uncomfortable, and that's definitely a problem to your patient. You're affecting them. Don't think that the next person will talk to them about it. Just if you have trouble, sometimes, like, I'm the kind of person a nurse can come up and be like, listen, I got to talk to my patient about this, and we're not really jiving. I'll be like, hey, I'll totally go have a talk with them. I can absolutely do that for you. Some of us are better at it than others. I don't like irrigating ears, so I'll pass that on to somebody, or getting bugs out of them. It's disgusting stuff. I'd much rather talk to somebody about their bowel and bladder. Urinary catheterization can either be intermittent or indwelling. We kind of talked about that in the PVR. What situations constitute an indwelling catheter placement? It's definitely going to be now with the CAUTI, you know, them trying to prevent CAUTIs, the EPIC system that you're going to use at OMC, those of you that go there, every time you're going to do a shift assessment, you're going to assess why this patient has a urinary catheter. And pretty much every facility has this now. They'll have a nurse-driven protocol where you can actually remove that catheter if those conditions no longer apply. Some of them are like end of life for comfort, so that patient doesn't have to be painfully moved and have, you know, painful sores. If they are comfort care and they are nearing the end of their life, they can have an indwelling catheter. If they've just come out of surgery, they can have a catheter, but usually it's just because they're going to be immobile for the night, and most physicians are going to want you to remove that in the morning. As soon as we can get it out, you know, the sooner the better. Then a non-healing ulcer to the coccyx or sacrum, you don't want that to be sitting in incontinent urine. You're going to introduce that open sore to more types of bacteria, you know, things like that. There's going to be an absolute need for it in certain situations. I had a nurse put in one on a patient she had had a CVA a couple weeks ago and was very immobile on the left side. And she was like a 2-person assist to get up. She had that left-sided neglect too. And we were short-staffed. We had no CNA. And so the physician told her, go ahead and put in a catheter because she's getting IV fluids. So I got there for night shift and I was like, that's not an appropriate way to treat the patient. We just have to, we're going to have to use a bedpan or something if we have to. But otherwise, we need to find the staff to be able to provide this lady with, you know, some dignity in urination. And so I could actually pull that catheter because they had written for nurse removal protocol, and it didn't fall under any of those categories that we could keep it. So I removed it a couple hours later, and the patient was like, what are you doing? Why did they put me through this? You know, so just be aware. If there's not those reasons, you need to tell the physician nicely that, you know, that doesn't fall under the protocol, and that's a risk for catheter-associated urinary tract infection that we cannot stand behind. We cannot tell the CMS that we've tried to avoid an infection. There are single lumen catheters used for straight catheterization. There are double lumen that's going to have a balloon on one side. That balloon is going to be inflated once you're in the bladder so that it holds it in there. And then you've got triple lumen for your CBIs, constant bladder irrigation. So you've got the 1 lumen that goes into the bladder to empty it. You've got the 2nd lumen for a balloon that's going to be probably pretty large. And then you've got the 3rd lumen that's going to be attached to a bag of fluids that's going in there and constantly irrigating that bladder. A healthcare provider will choose a catheter based on factors such as a latex allergy. Check with your facility and make sure that they're not using latex catheters. Just be aware if they are, because you see a lot of latex allergies out there, and sometimes we don't really know what that material is. There's a silver infused catheter that I've seen. I guess the silver helps treat a bacterial urinary tract infection better. Or, it's actually a product to treat the urinary infection that's, coated on the catheter tubing, which I think is awesome. It's like a localized treatment, like smearing triple antibiotic on an infection. And a lot of times when people come in with chronic Foleys and they've got these horrible infections, they will take it out and they'll put in this silver covered catheter to try to help. There's a Coude tip catheter if the patient's got a prostate problem. This one is curved at the end so that it can easily go around the prostate. And you have to kind of be shown how to use it. Size is based on the French scale, which reflects the internal diameter of the catheter. None of us can ever remember this because your IV catheters are your, 18s, 20s, 22s, and then your Foley catheters are 14, 16, 18s, and it's the opposite. Yeah, French as opposed to the gauge. So you can always ask somebody else if you can't figure out, or you can look at the catheter itself if you're getting ready to insert something. Some places have 16 as their norm. Some people have 18 as their norm. It's a little bit smaller. And you can tell by looking at that tube if it's wider, thicker or thinner than the other next to it. Smaller sizes are needed for infants, 5 to 6 French, which is a teeny tiny little thing. And then you've also got like your female urine specimen one. It's also going to be that teeny tiny thing. It just needs to slip into the bladder, gather some urine, slip right back out. Draining the bladder is going to be a little bit thicker because you want, a lot of volume to come out. The recommended balloon size for an adult is 10 milliliters. Long-term use of a larger balloon has been associated with increased patient discomfort because they've got that constant pressure, increased risk of catheter expulsion, which I cannot imagine expelling a 30 cc balloon out of my bladder. That's insane. But a lot of these people have had them in for a long time. Irritation and trauma to the urethra. If they do pull on it, it's a large balloon that they're pulling out. Typically a 10 cc balloon in the bladder is going to be about this big, but a 30 cc bladder is 3 times that, or 30 cc balloon is 3 times that size. So it's sitting in the bladder, which is not really much bigger than that in a normal bladder. But you will see them put it in people that, especially people that have like a very wide urethra from constant trauma. Incomplete emptying of the bladder resulting from urine that pools below the level of the catheter drainage eyes. Oh, yeah. So the balloon is below the actual hole where it's gathering the urine. So if you've got this big balloon sitting in the bottom of the bladder, your hole where it's emptying is up here. You've got a whole pool of urine underneath that's never going to empty. So it's just constantly going to be sitting there. An indwelling catheter is connected to a urinary drainage bag to collect the continuous flow of urine. How fast am I on here? Always hang the drainage bag below the level of the bladder on the bed frame or a chair so urine drains down out of the bladder. It should never touch the floor. Ambulatory patients can use a leg bag, so it's a little bit easier to manage. There is such a thing as a belly bag. I've never actually seen one. I have seen a stoma. It's probably similar to that, where it's a little bag strapped almost to the middle of the belly, and then it's got straps around it holding it in place. It's probably just for dignity, kind of to hide it. Always checks for kinks and bends. A lot of times, something that you think is a really bad obstruction type problem and you want to irrigate is just simply the tubing. Check that first. It's the easiest. Then routine catheter care is really important. With those CMS changes to reimbursement, a lot of times you're going to have to document every 8 hours that you did catheter care in a specific way. They have specific wipes. They have specific people responsible for it. They're really cracking down on that lack of hygiene. Empty drainage bags when they're half full. An overfull drainage bag can create tension and pulling on the catheter, resulting in trauma to the urethra and or urinary meatus and increased risk for CAUTI because it can back up. And then preventing CAUTIs. A critical part of routine catheter care is reducing the risk for CAUTI. We talked about taking them out with nurse protocols. Not every place has that. Just check with your facility and make sure there's an order for that. You don't want to take it out if you don't have the right to. You want to make sure that urinary drainage system is closed. When you take out a catheter in the kits usually, and I'm not sure about the ones you guys practice with, but they usually have like a red tape around that connection. So you know if it's been broken. If it's been broken, then you've possibly introduced bacteria. And then, like if you're switching to a leg bag and things like that, you will have to break that. Just make sure sterile is sterile every time. Many urine drainage systems are equipped with an anti-reflux valve, but the nurse should monitor the system to prevent pooling of urine within the tubing and to keep the drainage bag below the level of the bladder. And also you're going to be educating your patients that sometimes we'll go home with a catheter on these things because, again, they're not going to know. To maintain indwelling catheters, it's sometimes necessary to irrigate or flush a catheter with sterile solution. And it's really a process. Everything that you're dealing with has to be sterile when you're flushing, like the three-way catheters and a CBI. You're going to have the sterile syringe, you're going to have the sterile fluid, you're going to have a sterile bowl that you're getting the fluid out of, and then you're going to have a way of getting that, disposing of that urine that's not sterile that you're going to have to keep separate from all of that. You may have to do it. If you get the chance to watch, I think we had a student recently in clinical that wanted to do the irrigation, but they ended up just watching to make sure. I mean, that was an NG too, but anyway, it is definitely necessary to watch somebody do it before you try to attempt it yourself. Bladder instillations are used to instill medication into the bladder. I've never seen that, but I mean, it's totally understandable. Promptly removing indwelling catheters helps greatly in terms of preventing hospital-acquired UTIs. All patients should have their voiding monitored for at least 24 to 48 hours after the removal. They're going to be given 6 to 8 hours to void. If they're having the urgency to void and they can't go, then you're going to contact the physician, or there might be a standing order that'll say, okay, you can straight cath this patient one time, then monitor. You're going to want to do things before that, like I said, getting them up to a commode, filling them full of fluid so we can flush those kidneys and make sure that they're making urine. And then a symptom of an infection from a catheter can happen 2 days after. You know, bacteria doesn't automatically cause pain. So you want to tell them what to look for. There is also a suprapubic catheterization where they're not going through the groin, which is definitely more full of bacteria, dark and moist. That drainage tube is going to be surgically inserted. One thing to keep in mind with suprapubic catheterization, if you work in the ER or actually anywhere, a patient is going to have a suprapubic. If they pull it out, it needs to be reinserted immediately by somebody who knows how to do it. Contact the physician. If you wait an hour or two, that is going to be closed up in a lot of patients, and they're going to have a repeat surgery to put it in. And a lot of times, if you don't have the equipment necessary, you don't have an actual suprapubic catheter, the physician will tell you to just place a Foley. Just keep that hole open, inflate the balloon if you can, or just make sure that it's secure in some way to keep that surgical opening there, so that they don't have to have another surgery. A lot of people don't know that, and I've seen that happen where they're like, oh, it came out, we don't have another one, so we'll talk to the urologist in the morning. And it does not go well for the patient, usually, or the nurse. Care of the suprapubic catheter involves daily cleansing of the insertion site and catheter, much like you would a urethral catheter. They do leak sometimes. A patient still might put out a little bit of urine through the urethral meatus, but a lot of times it can really help in situations like a neurogenic bladder. There can be some inflammation when it's new. Sometimes you'll see people put little drain sponges around it, the gauze that's cut out for their tubing, but if that becomes wet, you want to take that off. External catheters. So something that we've dealt with for years is the condom catheter for a man that is incontinent or immobilized and they don't want to invasively treat that. They'll put just a sticky condom over it and gather their urine that way. You definitely want to be looking at that that head of the penis, because a lot of times it can be, tubing can be kinked, or they can be putting out so much urine that it's sitting in a spot of that condom that's going to cause redness and irritation and pain. But now, and make sure they don't have a latex allergy if it's latex, but now they have a female external catheter. And I don't know if you guys are going to see this in school, but I have pictures of one that we used in Auburn. Okay. So this is the PureWick external female catheter. I took a bunch of pictures so you can kind of see the size of it and how it works. It's for incontinent or immobilized females, fits inside the external labia. They're going to keep suction on continuously at 40 so that it automatically draws urine out of this sponge material. It has to be changed every 8 to 12 hours. Record and discard your output. It comes out in the suction canisters. And then still turn and check on the patient every 2 hours because it does sometimes leak. You need to make sure it's in place and it's not causing any problems. And it avoids the occurrence of a catheter-associated urinary tract infection. So this is my hand up next to it. You can see how big it is. So this is like almost like a tampon type material. It's like a cottony, squishy thing. And then the external part is a rubber piece. This part is what hooks up to the suction tubing. And then all of this pretty much goes inside the external labia. And so it's going to usually be an older or a larger woman. And they have to be pretty immobile because every time they move, the thing is going to slip out of place and it's not going to create suction. It's that rubber against the skin in completion around that cotton piece that causes the suction. So that's the rubbery piece and then the squishy little cotton piece. They are really nice when they work. They are really disgusting when they don't. And if they don't get changed every 8 to 12 hours, they stink. So if you do see these, a lot of times you're going to be using them on very morbidly obese women. And just make sure that you're checking, however difficult it is, that site, and that they're not turning the suction up too high. Check your suction settings every shift. Because we did have a patient with a family member that felt that wasn't enough suction and suctioned it up, turned it up to 120, and we had no idea. Nobody was paying attention. And we went to empty it and change the tubing and stuff. It was set to 120, and she did have like almost like hickeys, like purple spots there where she had been suctioned way too hard. Let me go back a little bit, sorry. Talked about we talked about that. Medications, lifestyle changes. In addition to interventions, the interventions for continuing and restorative care, rehabbing people and getting them back in their normal setting. Behavioral therapy is considered first-line treatment for stress, urge, and mixed urinary incontinence by using techniques to improve the control over the bladder emptying and restore some degree of continence. This may include lifestyle changes, pelvic floor muscle training, bladder retraining, various toileting schedules. They used to do an automatic urinary sling when they did a hysterectomy on a woman, because after they take out the uterus, the urinary bladder kind of falls, and so there's a lot of incontinence involved. But now they found that, it's past 2:30, isn't it? Gotcha. So now they found that it's not a good idea, that we need to do everything we can naturally to provide continence before we start intervening with catheters and with bladder slings and with mesh and things like that. So there's some more things on pelvic floor muscle training. I think we all know Kegels and toileting schedules. They'll put a patient on a toileting schedule every 2 hours or so to try to keep things as normal as possible. Intermittent catheterization we talked about. Skin care, definitely clean, dry, moisture barrier. And then evaluate your outcomes. Make sure things are working. If they're not, you need to reassess and maybe change some things that you're doing. Talk it over with the patient, with the physician. Just another important system in the whole assessment procedure. And make sure a patient knows that if things aren't working when they do get home, when to call their doctor, when to come to the emergency room. That's pretty much it. Do you guys have any questions? It's fascinating material. Absolutely. It's like, how much can you talk about it?
When you talk about the surgically inserted catheter, if it came out, what was
the suprapubic catheter?
Yeah, so what you say to do
if it got pulled out? You can put a sterile, it's got to be sterile. If you don't have a suprapubic catheter to replace it with, you can take a Foley catheter, any kind of catheter tubing really, as long as it's sterile, and place it in there far enough to be returning urine. And when it's returning urine, then you want to secure it in some way. If you think about it, if you got the long, big Foley catheter tubing, you don't want to insert it into that little bitty bladder because the opening between the skin and the bladder is only going to be this deep. You don't want to insert it all that way and coil it around and then insert a balloon. So find some way to just keep it secure there and call the physician and let them know what's happened. A lot of times a urologist will come in and replace it right there, even if you're in a rural setting, because they're that, prone to having another surgery if it stays out longer than a couple hours. Well, thank you guys so much. I appreciate it greatly. Thank you. And quickly, I want to tell you that I've been in this situation that you guys are in, and you're looking forward to like what appears to be a really long period of time that you're sitting in school and spending most of your life sitting there. But I did it with a newborn baby, a 10-year-old, a full-time job as a CN at nights, and no husband to help me. So you can absolutely get through it, and you'll be rock stars when you finish. Thank you.